Hi everyone, shall we kick off if that's okay? We're going to just spend a little bit of time talking about left atrial pressure, which is super important for analysis in the critically ill, and unfortunately not without its fallacies in terms of its assessment. So we'll go through lots and lots of cases as we go through this. Please interrupt me as we go, and just might ask a few questions as we're going through it. So let's start off with this idea that first of all, filling of that left ventricle is an active process. And as you can see from this, beautiful MRI 4D flow picture, you can get this idea that during diastole, which is this frame that's just repeating, there's almost like this elastic recoil of that left ventricle as the mitral annulus gets pulled up towards the top of the heart, towards the atria, and that sucks blood into the left ventricle. And I use that to just keep that idea that, therefore, if you're starting to get problems with the if you're starting to get problems with the left ventricle, like systolic dysfunction, that recoil is impaired. This is one of the first things to go, is that elastic recoil in the heart. So raised left atrial pressure is super common in heart failure, and it's also therefore super common in the ICU, where we can get impairments of left ventricles all the time. The next thing I'm going to say is that, unfortunately, a lot of the guidelines that we have that are relevant to the critically ill, they're not validated in they're all in the non-critically ill, in the cardiology population. They're not brilliantly validated in the ICU population. So as you'll see, we're not quite as certain sometimes on estimating diastolic dysfunction as in the cardiology population, but echo is still incredibly useful. But I think it's probably more useful and more accurate, and we use it as a monitoring tool, as in we're going to do something and then, we assess the left atrial pressure, we then do something and then we reassess it. That's how I find it most useful in the critically ill. And why do we want to measure it? Because it's absolutely integral part of the cardiovascular system. I'm going to go through when I think we should be assessing it. I'll go through how to assess it, but then most importantly about what's going to influence and what we're going to influence with left atrial pressure, because it's useful in a great number of patients, and I'd potentially go so far as to say it's one of the most common things that I think I assess in my practice. Okay, left atrial pressure. We're going to assess that by looking at the inflow to the left ventricle, by assessing our mitral annular tissue movement. We're going to look at our pulmonary veins. It's still, that left atrial pressure assessment is still a part of the cardiovascular system, which means we need to look sort of downstream from that, or is it upstream? Upstream of that, that means we're going to look at the lungs. We're going to look for B lines, raised interstitial fluid. We're going to look for effusions. If we're going to get raised left atrial pressure causing effects to the lungs, it can also cause effects to the right side of the heart. So particularly the pulmonary hemodynamics. And this is where we can start to get this idea maybe of, we've got post-capillary pulmonary hypertension, which is going to be caused by raised left atrial pressure. And that's different from the pre-capillary pulmonary hypertension, which is where it's going to be something that's caused from lungs or ventilation or pulmonary hypertension, or chronic thromboemboli or something. Okay. And then if we're looking at that causing right ventricle dysfunction, you can even go so far as to see problems with congestion that comes on there, and maybe VEXA slips into that, but I'm not going to talk about this in that lecture. Okay, so left atrial pressure, big part of the cardiovascular system. It gets affected by left ventricle systolic function, and it affects then the respiratory system. It affects the RV, pulmonary hemodynamics, and it affects the right ventricle function too. So let's go through when and how to assess it. And we'll start off with an example that we had a month or two ago. So let's have a think. An 80-year-old female. She's presenting with fever, had a Met call up on the ward, and we found that she's got some urosepsis, protus mirabilis bacteremia. She's a bit frail. She's known to have severe AS and was awaiting a TAVI. So this lady, I'd be putting in that category of being, pretty high risk if we're going to start trying to give her an anesthetic, trying to intubate her. So, but she's got septic shock. We know we've got to give her some fluids to try and help with this, but we've also got to know that if we give her too much fluid, that's going to be a bad thing. Okay. So fluid management is really important. So I'll use an example, and then I'm going to get you guys to do all the hard work on the next few examples. So the way I use left atrial pressure in this lady's assessment was to look at that inflow and I could see that E to A ratio was about 1. I can see that deceleration time is about 370. So we know that when it gets to be greater than 2, that E to A ratio, that's a sign of restricted filling. When we know that that decel time gets less than 140, that can be a sign of increased filling. We're going to look at our mitral annulus tissue Doppler, and we look at our E prime velocity. And we can see our E prime of the septum is less than 8, which suggests that there's impaired relaxation. And you can see it here at 0.6. We're going to look at our lateral, which is 7, which is less than 10. So that means that we've got some impaired relaxation. And I then go to look at the E to E prime ratio. And you can see it here, it's greater than 14. Okay. So putting all that together on that admission echo, when she came into ICU, we can say that she's got some markings of impaired relaxation of the heart, but she's got an okay E to A ratio. She's got an okay looking decel time. So she's got some markers of raised impaired relaxation, but she doesn't have hugely elevated left atrial pressure maybe at the moment. Okay. And I'll show you why I'm taking all of these with a pinch of salt, because they're not validated in patients who've got septic shock. So at this stage, to be honest, I'd be almost saying I don't know whether she's got raised left atrial pressure. I looked at that 2D picture, maybe I could show that. And you see that interatrial septum, it's a little bit pushed over to the right. So I'm going to sit there and go, I don't know, man, but I know if I give this lady 150 mils too much fluid, it's going to end up in her lungs, and intubating her could be a real mess. She was ideally not for intubation. You know, this is a really important decision. So this is what she looked like before. We then gave her 750 mils of fluid, so in 250 mil increments, and we saw this huge difference then in her left atrial pressure estimates. And I don't have a lot of evidence to back up some of this, but it's not subtle. I've gone from an E to A ratio of 1 to well over 2. I've got 4.1, excuse me. I've got an E wave Vmax, so that's the peak velocity of my E wave, which has jumped from being about 1 up to 1.5. And we know that's a load dependent measure. And then I've got my E to E prime average, which jumped from being in this gray zone category up to being 21. And the decel time went from being okay to, again, a signal of restrictive filling defect. So I found this a really useful thing in caring for this lady, to know that this lady, therefore, did not need any more fluid. She was not even close to that 20 to 30 mils per kilo that we're recommending to give to septic shock patients. But we've got a nice change that we can, so we're using this as a monitoring tool as much as anything. So let's go through a few specifics. That's just the example of how I think it can be used in clinical practice. Now we'll go through, who else that we can look at it on. So as I hopefully I've shown, I can give it to these patients who have got sort of at risk of positive fluid balance. We're going to use it in patients that have got some form of either acute or chronic LV dysfunction, because we know that can raise your left atrial pressure. I'm going to use it a lot in patients with respiratory failure or ARDS or pulmonary hypertension, because, as I said, raised left atrial pressure can affect your lungs and your pulmonary hemodynamics. And then finally, I'm going to use it a lot when I'm trying to look at weaning patients from mechanical ventilation who might be at risk. Okay, so let's go through a few of these examples. Okay, yeah, hey, one.
Sorry, Sam, is there a reason you are talking specifically about left atrial pressure and not calling this diastolic function?
Yeah, very much, because I guess I'm not interested too much in diastolic dysfunction, I'll be honest. I report it a lot when we're doing outpatient echoes. What I'm interested in critically ill patients is, do they have a raised left atrial pressure or not? That's what, and correct me if I'm wrong, because I'm still on this journey trying to figure this out. I must have given lectures on this for 10 years and I still don't think I've got it quite right yet. But at the end of the day, hopefully with this lecture, you'll see I'm trying to keep it pretty simple. And it's all about left atrial pressure, right? It's all about trying to figure out what that pressure is. If it's getting too high, you're going to mess up the lungs.
Sure.
And if you get it too low, it doesn't fill the left ventricle. So I'm very deliberately not talking about diastolic dysfunction because I sort of don't think it's that clinically important whether you've got someone who's got grade 2 or 1 diastolic dysfunction. I think it matters
Right.
whether they've got raised left atrial pressure or not. And more importantly, I don't think I've got a lot of great evidence. The ICU literature is pretty scant, I'll be honest. And I'll present some of the best papers I think they're out there. But I think, and am I wrong in this? I mean, we're all pretty experienced clinicians on here. I mean, I think that's what we care about, right? It's left atrial pressure, not diastolic dysfunction. Yeah, Damien.
Hi, John. I guess the reason that patient might have got fluids is there was concern about preload dependency with severe AS and vasodilatation, and in the context of sepsis. How obviously what you've shown is that giving fluids resulted in harm. How would you use echo in that patient to determine preload adequacy in the context of severe AS?
Yeah, great question. I mean, I think we look at gradients, and the gradients did go up in this lady, but I'm not, I think I could probably talk the whole hour about that lady, to be honest. I use lung ultrasound as well to make sure that we weren't overloading her backwards, and I think you've got to balance it out, because the next thing to say is this fluid doesn't stay in her system indefinitely, right? It's also going to become leaky with the sepsis and the glycocalyx dysfunction. So I think you've got to monitor hemodynamics. She needs obviously to have an arterial line. I think some of the picos and things like that are not going to be great in these patients. I think there's going to be, if you're going to try and monitor hemodynamics without an echo, you're going to need to have validated hemodynamic monitoring devices. And I think you've got to try something, do it in small increments, like giving fluid boluses in a small manner, and reassess. You're going to have to monitor her somehow and see what's working. If you overload her, you're going to put fluid into her lungs. If you underfill her, you're going to make gradient potentially worse. And so you've got to balance it out and repeat assessment.
Meaning like a low flow gradient kind of thing on
Yeah,
echo?
I mean, but I think if you've got if you've got not enough fluid on and she's then starting to work harder, you can make that gradient even worse. If she's got reduced afterload from from the septic shock, that can make the gradient worse. I think you've got to make sure that she's got adequate afterload, and that hence the worry I had with giving her the anesthetic. Right, if you tank her afterload, with a septic shock, that can make the gradient worse. That's all I was meaning. So I think hemodynamic stability is really precarious in that patient, which is why repeated assessment with echo is just beautifully suited to that patient, both heart and lung. Let me crack on going if that's cool. Because we're doing this for people who are just again starting off, forgive me if I'm teaching everyone stuff that they know, but I think it's really important as people are starting off, just to remember some of the measures that I'm talking about. So the conventional measures for measuring left atrial pressure include, first and foremost, putting a pulse wave Doppler box at the tip of the mitral valve leaflets in the apical 4-chamber view. And we can look at that flow into the ventricle. So you've got the E, the early wave filling that happens just after the T wave. So early filling, and the A is then the atrial kick. We're going to look at the mitral annular velocity. So that's using tissue Doppler imaging, another form of pulse wave Doppler. And we look at both the septal and the lateral. And again, the E wave is the one that's the first big downward deflection, and after the T wave. And the A is the atrial kick. The other conventional measures they talk about include tricuspid regurgitation Vmax being greater than 2.8, and also the left atrial size. Both of those things, I think, are affected by, so first of all, the left atrial volume is going to be affected by chronicity, and you can get acute diastolic dysfunction and acutely raised left atrial pressure in the critically ill. So I don't think this one is super relevant to when we're trying to estimate whether someone's got that raised left atrial filling pressure or not. We've got about 1 million things that can raise up our TR velocity in the ICU population, not least hypoxia, hypercarbia, acidosis with reflex pulmonary vasoconstriction, PEEP, tidal volumes, mean airway pressures. All of these things are going to affect our TR velocity. When we look at E to E prime, I'm going to show you that it is not a perfect measure. And we're comparing the E to E prime is comparing that big E wave with that small E prime. Greater than 14 suggests to be raised pressures. All of these things are not accurate. You look at them as a static time point in the critically ill. And that's why you need to do repeated measures after you've done something. Other little pearls that I think are really useful. First and foremost, the bottom left image here, looking at the interatrial septum and seeing if it's bowed over to the right. Seeing if we've got B lines on our lung ultrasound, bearing in mind that B lines are just indicative of fluid in the interstitial space, and they can be caused by lots of things, including raised left atrial pressure. D cell time can be useful. So you can see in normal when it's greater than 240 milliseconds, and you've got that long slope, as opposed to super abnormal when it's super sharp, less than 140 milliseconds. And then the other one is my favorite, which is because you can't fake it, and it's always a sign of raised left atrial pressure, which is looking at the S to D wave ratio in the pulmonary veins. So normally you have a big S wave, small D wave as blood flows into the left atrium. If you have raised left atrial pressure, you can get systolic flow blunting, and I'll show you some good examples of that. A bit easier to do with toe than transthoracic. So these are the guidelines that come out by Sheriff Nagwe and all the great and the good from the American Society of Echo. These guidelines are amazing in the non-critically ill, based on some really, really solid research as best they can provide. New guidelines are coming out soon. They're bringing in things like left atrial strain and stuff. I don't mind these 2016 guidelines because they try to simplify things and have less reliance on just one value. So this is the classic ASE free document guidelines. And in this figure, if you've got a normal ejection fraction, use the top one. You look at those 3 or 4 different values that I was talking about, the E to E prime, your mitral annular E prime velocities, your TRV max, your left atrial volume. And from there, you can figure out whether someone's got diastolic dysfunction or not. Are they at risk of raised left atrial pressure? If you've got bad cardiac function, it will be in the, depressed ejection fractions, hypertrophy, structural heart disease, or you've got diastolic dysfunction from panel A, then you can go and have a look at panel B, and you can start off by looking at your E to A ratio. Depending on that being normal or abnormal, you then go and have a look at your E to E prime, TR velocity, and left atrial volume index. I hope you're starting to get an idea that I bagged out a few of these measures before in the critically ill, which means that we can use these and give us an indication, but some of them have real problems in the critically ill. But I like the idea that they're not relying on just one value. They're suggesting use lots of different things. And then there's this focus at the end of whether you've got normal left atrial pressure or whether you've got raised left atrial pressure. So what the hell do we do in the critically ill? Well, they looked at these guidelines with Michelle Slama's group, Apinamia, and they had, I think it was something like 50 or 60 patients. I could have got that wrong. And they had these patients that had wedge pressures that they could then measure. And what they found is that, unfortunately, using those 2016 guidelines, that the sensitivity and specificity was like 0.74, and you've got an agreement value of like 0.5. That's not magic. It's not awful, but it's not brilliant. What I loved what they went to do is they actually just tried to then simplify it down in this paper. And they just had this simple thing that said, if your ejection fraction is less than 45%, you look at your E to A ratio. And this had the best way of trying to discriminate between those with elevated pulmonary artery occlusion pressures versus those without. Okay? So if you've got a depressed ejection fraction, you use your E to A ratio greater than 1.5. That's got the best sensitivity and specificity for saying whether someone's got elevated wedge pressure or not. On the flip side, if they had more normal ejection fraction or greater than 45%, you just look at the E prime velocity, which is a really good marker of impaired diastolic filling. And that was pretty good at saying that you had a normal wedge pressure. If you've got an okay ejection fraction, a normal lateral E prime velocity with no mitral calcification, no regional wall motion abnormalities, no pacemakers, maybe that means that you've got normal left atrial pressure. Okay. So I sort of take away from that, bad LV, raised E to A ratio, raised wedge pressure, normal ejection fraction, normal E prime velocity, normal wedge pressure. Everything else in between, we're going to need a bit more info. Again, what I find a trouble with this is we're looking at a static parameter and we're not doing repeated measures. So, clearly you can see from the curves here, and again, it's not perfect, but it's nice that we're trying to simplify it down a little bit. And I think with the repeated measure, you can actually then make this super useful and tell you which group you're in with a lot more certainty. Okay. So they've looked through their literature when they've done this kind of measuring before, and you can see the way that there's this scatter plot between those with just purely E to E prime, or just looking at your E to A, or just looking at your D cell time, which is probably better than most. And you are going to get this difference in all of them, which helps make sure that you can say that they're specific, but they're not that sensitive. So, and if you've got, a wedge pressure, you've got an E to E prime that's greater than 15, it's not perfect, but it's okay to say that it's raised. But if it's less than 8, then again, we're probably okay saying it's normal. But again, you're going to have discrepancies in there. So not perfect as a static measure. Evidence has shown it's not great in the critically ill, and therefore you've got to do other things. And that's what I'm hopefully going to show you with this. Emma's done a really nice paper with Prof McLean suggesting that we're going to have a look, trying to keep it simple, looking at just your E to E prime and lateral E prime. They suggest you do your TTE, looking at all those different values that we spoke about, including the LVS less than 45 and the E prime, and use your lateral E prime and your EF, mixing it with lung ultrasound and PA catheter. And then talking about probability is maybe what Emma was suggesting in this. I think, you can't say it for 100% certainty, so you have to do your best with probabilities. I think we're used to dealing with that in the critically ill population. And then you can try and treat underlying causes, be them ischemia, fluid, treating arrhythmias, that kind of thing. So I appreciate the new guidelines, if you like, in the critically ill, is trying to make it as simple as possible. I still think it misses some of the actual nuances of that repeated analysis. So this is what I'm going to try and show you. Here, let's have a think about what influences left atrial pressure. We've got LV function, arrhythmias, valve disease, RV dilation, fluid status already shown, and mechanical ventilation. So let's go through a couple of examples of these. Okay. We're particularly going to talk about, in the critically ill, positive pressure ventilation, because obviously ventilation is going to have a big role. And let's try and remember that as you mechanically ventilate someone, we are going to, when we increase up their intrathoracic pressure, you're going to decrease the filling to the right atrium. You're going to increase up their right ventricle afterload. That means that you're going to have reduced blood going across the lungs into the left atrium. So you're going to reduce that LA preload or LV preload. And also we're going to reduce the LV afterload because of that reduced pressure in that transmural pressure, right? So if that's the pressure inside your intrapleural space and that's your pressure in your ventricle, when you put someone on positive pressure ventilation, that goes up a lot more than inside your heart, which means that afterload is reduced. Does anyone need me to go through that again? Because it's pretty important. I presume, I feel like the audience is going to know that pretty well, all that stuff. You guys happy with that? Cool. All right. So I'm going to show you how we use that in the critically ill. So this guy's a truck driver. He had a bad heart from conscious VT, and he ended up on the ward as they were trying to settle him down, and he went into fluid overload. He'd had a bit of fluid that had been given to him, trying to resuscitate him, and he ended up, up on the ward in APO and had a MET call. So he's desaturating on the ward. He's agitated. He's not tolerating his CPAP, and we had to intubate him. We gave him good levels of PEEP, trying to give that afterload reduction to the LV and clear his chest. And after a few days, negative fluid balance, everything looked better, but he still had he had a chest x-ray that was getting better, but he was a bit tricky to wean off the ventilator. So what we can do is we can have a look at him with transesophageal echo. And what we can see here is that we've got significant mitral regurg that's there, and we've got this massive E to A ratio. All right, so LV function's okay, MR's significant, and we've got this raised E to A ratio. That decel time is 190. We've got an E to A ratio of 3, E to E prime of 14, systolic blunting, and a good sized Pisa radius suggesting we're at least moderate. So what would you estimate this guy's left atrial pressure to be? Raised or not? Give me an up. Beautiful. So this is raised. This guy was on a PEEP of 10 and difficult to wean from the ventilator. So what's pretty easy to do is then you can just do a spontaneous breathing trial whilst you're doing the toe and turn down the PEEP. And turning down the PEEP to 5, it was really interesting to see that everything got worse. So the E wave Vmax went up. The decel time went down. The E to A ratio got worse. The E to E prime values went right up, and the S and the D wave got even worse, and the Pisa radius extended. Now you can probably argue that you can make the Pisa radius, the Pisa radius you can change around a bit. It's a little hard to do, right? And maybe this is an eccentric jet, but the rest of it is hard to fake. Or maybe the Pisa radius you could fake, the decel time you could probably, fake as well. But it's hard to fake an E to A ratio change. It's hard to fake an E to E prime ratio that changes like that. And it's hard to fake an S to D further blunting. And I think that's really important to know that this guy's failing his spontaneous breathing trial because he's just got loads of fluid going into his lungs, right? So again, using it as a monitoring tool with toe, it's great, and you can have a good look at your pulmonary veins. Okay, what about this one? Hey, do you want to crack at this? So 35-year-old male, dilated cardiomyopathy. He's got severe LV dysfunction. Okay?
Yeah.
So take me through how you're going to assess his left atrial pressure.
So on 2D, there is bowing of the intraatrial septum to the right.
Sweet.
And just subjectively, LA size looks enlarged, but I like to check the volumes.
So it's not his first rodeo. He's going to have raised chronically elevated left ventricular end diastolic pressures, which is why his left atrium's a bit big.
Yeah.
Cool. Nice. Have I ever told you that's what Faraz calls it? Faraz calls the left atrial size the HbA1c of the heart. So if it's dilated, you know that they've got chronically elevated pressures. Yeah, nice.
Yeah. And I think there is at least moderate MR as well. There's a Pisa dome and there's a almost triangular shaped spectral Doppler.
And it sort of hits the back of the wall of the left atrium.
Yep.
But do bear in mind that we've only got it's only at 47 the velocities. Nice. What about this?
Again, there are a lot of indicators of raised left atrial pressure. Like E velocity is really elevated. Septal E prime is abnormal, abnormally low, as well as a lateral E prime. And TR velocity is very high as well.
Yeah. So which out of all of those things that you said, so you're going to say, I imagine that you think the left atrial pressure is up or down?
Up.
Yeah, nice. Which one of these is actually the best marker according to the literature?
So he has poor ejection fraction. So I'd look at E to E prime.
Yeah, man, nice, excellent. What's your cutoff?
14.
Very, very good. So that's exactly what they suggest in the ASC guidelines here. So when you got significant MR, it can be a little tricky trying to estimate what your left atrial pressure is, whether it's raised or not. Taking it as a static measure, just a 1-point time frame, having a look at it, The best one that they suggest there is the E to E prime being greater than 14. So really well done. So you do that, particularly in those patients with depressed EFs. You can also look at these isovolumetric relaxation times, and I'll show you an example of where I've used that, and also look at the AR to A duration. But again, to be honest, I don't do that too much. So yeah, with significant MR, particularly looking at E to E prime, the literature would say no validation in the critically ill that I'm aware of, or your IVRT. Cool. All right, Damien, do you want to have a crack at this one? So this is a 60-year-old male, post-op diabetic toe amputation, background of diabetes, hypertension, chronic kidney disease. You'd see these patients probably every day coming through hospitals, and they're hypotensive in recovery. You've got cool peripheries, warm centrally. They've given a litre in intra-op, and they've given a litre in recovery, and the ICU is full, but they want to bring him in for a metaraminol infusion. I'll be honest, these are the kind of patients where I start thinking, please tell me this patient can have some more fluids and they don't have to come in. So what are you seeing on the echo?
Yep, so just looking from top left around, so parasternal long axis, thick walled left ventricle, well preserved ejection fraction in the context of a small cavity size. Left atrium doesn't look particularly big. Right ventricle doesn't look particularly big. No B lines in the lung fields there.
Nice.
Okay.
What do you think about the left ventricle thickness?
Yeah, so it looks like there's fairly concentric hypertrophy in the parasternal view below. I'd like to measure it. Looks, at least 1.5 centimeters, if not more, there.
Yeah. Nice.
And
so here you go. What do you think of all of this?
Yep. I'm on a bit of a small screen, so I'm just going to.
Oh, I can read it out to you.
Try and zoom in. So that looks like there's a fairly prolonged deceleration time. Just looking at the shape of it on the top left.
220 milliseconds. Yeah. Sorry, I've got a 340 and a 220 measured there.
Oh, beautiful. I'll take the 340. Looks fairly long. And then the A wave's much bigger than the E wave. So you've got reversal of the inflow pattern. U to E is stonkingly high. And there's no tricuspid regurgitation, so a bit of a mixed pattern, but overall looks like a typical thick, slow relaxation, high filling pressure kind of patient, but mainly a delayed relaxation, thick wards patient.
Which means that they'd be super at risk of raised left atrial pressure, right?
Yeah.
But then we've got a whole bunch of things that maybe it looks normal, and you've got some things that make it seem it's raised. So I don't know, if you had to say, is the left atrial pressure raised or not? What's going to happen? I don't know. Do you think it's raised or not?
So I'm not sure if this guy would be fluid tolerant or not. He's clearly got delayed relaxation, but then there's features on the echo that make me think that, he's got a small, well contracting right ventricle. He's got a small cavity size. Might be reasonable to give him 250 and reassess.
Yeah, very nice. So I did not do that, but I think it's very sensible. I think it'd be a great call. One of the things that I was trying to look at with this guy was the interventional relaxation time that we spoke about. And if you're saying that that's less than 60, you can suggest that that's more indicative of raised left atrial pressures. And this guy's certainly was. So, I mean, I would have thought that was. So I used the interventricular relaxation time that we spoke about in that last case, in this case, to kind of go with the idea that this guy is an absolute sitter for it. He's probably got some raised left atrial pressure. And I would do, if I had a chance to do it again, I'd do exactly what you suggest, which is give him 250 mils of fluid and reassess all of this and see if it went in the other direction. Really nice answer. All right. Lucas, hello, mate. Nice to meet you. I hope I haven't seen you a lot on these. I hope you don't mind. If your camera's on, am I allowed to ask you a question?
Yes, you are.
Fantastic. It's really nice to meet you. Where are you based?
I'm based up at John Hunter Hospital as well. Damien has roped me in. I'm one of the fellows up in John Hunter too.
That's wicked. Well, mate, welcome. Anytime you want to come along, you're more than welcome. 80-year-old female, urosepsis, 2 liters of fluid in ED on 10 mils an hour of metaraminol. What do you think of that picture?
So yeah, it's very abnormal apical forward chamber. I think what stands out the most is their Both right and left atria would appear to be larger than their corresponding ventricles. So I think straight off the bat would suggest there's a degree of chronicity in this lady's heart failure.
Yeah.
What else am I looking at? So in terms of the left ventricle, it's I'm seeing concentric thickening throughout on this view. Again, the right ventricle, you'd want to measure the TAPSE whilst you're here, but it looks to be performing in keeping with the rest of the heart.
The other thing, can you see at the back here, we've got these kind of black lines that are there?
Yeah, pulmonary veins.
Yeah.
Yep.
Yeah, I don't think those are pulmonary veins, though. I reckon it's something to do with this stuff here. Can you see my cursor?
Yeah, the calcification around the aortic valve.
Yeah,
and
nice.
shadows.
What do we call that? Because that
So
opening of the valve, you see, it's almost
shadow.
like in the middle rather than at the sides.
Yeah, so that's acoustic shadowing, is it? Yeah.
Yeah, nice. Acoustic shadowing from
mitral annulus and
mitral annular calcification. Excellent. Yep. And so all of that stuff mixed in with that, and you can see the interatrial septum pushed over to the right. You know, with, again, as you said, that left atrial size, that mitral annular calcification, the interatrial septum, all could be pointing towards raised left atrial pressure. Nice. And then we've got a decel time of 129. What does that mean?
So that is rapid, suggesting elevated left atrial pressures.
Excellent. We've got an E to E prime of 30.
Again, very elevated in keeping.
Nice. With magic number 15. Anything greater than that's raised. We've got a TR velocity there, which is 3.3.
3.5, 3.3. Yep.
It's high. So and you've got a massive left atrium. So which one do you think is the best for this patient?
So 80.
What are you going to take in that one?
So
if you had to take one of these values, which ones do you think to look at?
Probably E to E prime, but I'm trying to think about your delineation of normal versus reduced ejection fraction has looked.
Yeah. So these is a great example where looking, because the patient's rhythm is AF. So don't forget to look at the rhythm when we're trying to assess this, because it means that the E to E prime stuff is a little harder, I think. And so using these other values can be useful, and particularly looking at the decel time, I like, and looking at the lack of variation in an E wave velocity. So those are the ones to look at when you're dealing with AF. And absolutely, I totally agree with you. This lady's got raised left atrial pressure. She needs to not have a lot more fluids and try to be giving her catecholamines instead. All right.
Sam?
Yeah.
Sam, just from a newbie echo teaching perspective, just for the variability, you would just turn the sweep speed all the way up and get how many on a screen? How many on a screen?
5.
Okay.
Maybe do 2 of them so you can see, and just lack of a variability suggests raised left atrial pressure. I love the decel time in AF, less than 130, 140. That's raised. You know, the further out it is, the less raised it is. So yeah, it can be hard to try. And the E to A ratio doesn't work quite so well. The E to E prime I don't find works quite so well, particularly if you've got mitral annular calcification. So then,
and is there any form of definition? Is there any form of definition as to what variability is with the E-wave inflows?
Just not massive. That's all.
Just whether it looks horrible or not. Yeah.
You got it.
Okay.
You got it.
All right.
And sorry, Sam, one more question. Does the calcification itself cause error in the E prime measurement, or just
precisely? Yeah. And it's a really so you just got to be really careful you don't use it with the E prime measurement.
Okay.
So because the calcification stops it moving, and so you don't get an idea of that true relaxation of that left ventricle.
Yep.
Nice. So a few little pitfalls in there, and I hope a few pearls. Okay, so that was all the stuff that influences the left atrial pressure. So that was mechanical ventilation, MR, arrhythmias, LV function. I think that was about it, wasn't it? RV function can be in there, a bad example of that. But now let's talk about what the left atrial pressure can influence. And so this is all that stuff behind the left atrium. So it's going to be your lungs, it's going to be your pulmonary hemodynamics, it's going to be your RV function. So, hey, back to you. 45-year-old PJP, pneumonia after renal transplant. She failed high flow nasal prongs, needed intubation. And we're at maximal conventional ventilation. I've got a peak velocity, peak pressure here of 31 on pressure control ventilation. I've got tidal volumes of 300, and that's with PEEPs of 12. So I've got a driving pressure of 19. I've got terrible compliance, with a driving pressure of 19. I've got tidal volumes of 280 mils. I've got a rest rate of, what's the rest rate there? It's something high, like 30, trying to blow air into this lady. And I've on 80% oxygen or 90% oxygen with PO2 values of 80. So I've got a PF ratio that's less than 100. So these are the kind of guys. I don't work in an ECMO center. I'm not as lucky as you guys up at the Hunter. I think these guys would, I imagine, be considered for ECMO straight away. We're going to always have a look at trying to do conventional things with proning or thinking about nitric oxide. And normally the first thing I'm going to reach for is nitric oxide because it's, it's not without its difficulties proning patients. So we'll have a look at that. But again, we're always taught with this ARDS pattern that we can see with these sort of 4-quadrant infiltrates that we got to make sure that the left atrial pressure is all right. So, hey, Juan, just help me out again with this one. What do you think?
Again, so it's on this 2D and color flow Doppler. Again, there's some concerning features. LA looks enlarged. There is hypertrophy of interventricular septum. There's MR, and there also seems to be significant TR as well. So I'll be worried about raised LAP, left atrial pressure on this patient, but I'd like to know some other numbers.
And the right in the LAP, the intratracheal septum's pushed over to the right in that 2 chamber, even with the TR, right? Can you see the?
Sure. Yep. Oh, yep. Okay. Yep.
And I think we got a diastolic bounce of the interventricular septum, suggesting a volume overloaded state. Cool.
Yeah. Okay. Yep.
Yeah. So again, just trying to pick up all evidence you can. What rhythm are we in? I think it's sinus. Okay, what about this stuff?
Again, well, I think in here, I'm worried about pulmonary or
yeah, nice. Keep going.
Yeah, probably
beautiful.
Pre-capillary though. There's like mid-systolic notching.
Yeah,
suggestive
maybe,
of pre-capillary pulmonary hypertension. But also
which kind of makes sense with ARDS and ventilating the hell out of her.
Yep. So you're right.
She's getting PEEPs at 12, driving pressures at 19. You can imagine we're causing a bit of stress on the capillary system, right?
Yeah, definitely. Also there is again, decreased pulmonary acceleration time, suggestive of raised pulmonary artery pressures.
Very nice.
There is high TR velocity, again consistent with raised pulmonary artery pressures.
And then we've got an RVOT VTI of 10, so suggesting reduced RVOT stroke volume as well.
Sure. So
normal or abnormal RV function?
I mean, I'd call that abnormal.
Yeah, good man.
Yeah,
but she's got a normal TAPSE of 19.
Yeah, but I mean, the longitudinal function on TAPSE might be normal, but I mean, just subjectively, like if I just subjective assessment, if I had to guess a VAC, I think it'd be reduced. It's also dilated. Yeah.
Well done. Yeah, so it's dilated. So the normal basal value is like 4.8 centimeters and 32. Here we can see it. So it looks dilated, measured to be dilated. The RVS prime is less than 8, but it's not off the charts, but it certainly doesn't look normal. TAPSE is okay, but visually and that bellows function is down. So I totally agree with you. I would call it even moderately abnormal, and it's mildly dilated. Great job.
Yeah, there is again, large. Oh, I think there's at least moderate MR here, with a piezo and probably a wide vena contractor, and dense, dense
and a
rectal
dense profile, very nice. It's not quite as bright as the forward flowing blood. Absolutely, I agree with you. You've got some good going moderate MR, and we've got dilated left atrium as well. Nice. Tell me what each of these means. So
again,
an E velocity of 1, is that high?
Yeah, it is. Yeah, it's high, it's abnormal. I don't know about, I actually expected it to be a bit higher, but maybe that's just
good call. I know what you mean, because I was going to say it sort of seems a bit normal to me. I was expecting it to be higher. Yeah, fair enough. Yep.
Yeah.
So it's not perfect by itself. We got an E to A ratio of 1.4. Is that normal or abnormal?
It's abnormal. Yes, abnormally elevated. And
it can be normal as well, remember? So it sort of starts off being between 1 to 2. It then goes around the other way as left atrial pressure rises up, goes back to that, and then goes over 2 when it's severely abnormal. So it's a bit of a trick question, excuse me. So an E to A ratio of 1.4 can be normal or can be abnormal. You don't know. Same for an E wave velocity of 1. Can be normal, can be abnormal. You just don't know.
Yeah.
And that's why you need some of these other values. So we've got an E to E prime of 20, which is obviously greater than 15. What about this here? What am I measuring here?
So it's a pulse wave at pulmonary vein. You're looking at pulmonary vein flow. I think there is systolic flow reversal.
Nice. I think it's a bit, it's a blunting. It's definitely smaller.
Blunting. Okay.
Yeah.
All right.
Nice one. Nice one. So I care about that because they've got raised left atrial pressure. And that's the one thing that we, in these patients, I reckon we miss this all the time. We talk about trying to optimize fluid balance. I'm not sure we sometimes do a great job. Maybe it's just us, but I think I don't go looking for it enough in these patients. And you need to reassess them because especially if you're about to put them on nitric oxide. And that's, I guess, my new sort of big bugbear is if we're going to start nitric oxide, you've got to check this out. Because the clinical team who were I wasn't looking after this patient, but the clinical team were going to put this patient on nitric oxide, but they hadn't seen this left atrial pressure estimate, which I felt was raised. I wasn't 100% sure, but I'm pretty sure there's lots of things, just like Haywan said, to suggest it was raised. And if you put someone on nitric oxide and you pulmonary vasodilate them, if you've got raised left atrial pressure, then you're just going to flood the lungs with that raised pressure, and you kind of almost like open the floodgates so that this post-capillary pulmonary hypertension can then cause increased interstitial fluid in the lungs. And so it's really important, I felt, to diurese this patient first, to then get them, and you can see the change. So we didn't know whether some of these values were normal or abnormal. They certainly have normalized even further when we diurese them and get an E to E prime less than 11. Yeah, Damien.
Hey Sam, have you got any information or papers about how these things change linearly with time?
No.
So it looks like most of your benefit here is from the E inflow changes rather than the relaxation changes and the mitral changes.
Yeah, absolutely.
Like your mitrals have only changed by 0.01, and most of it has come from inflow. The E waves, because
they're pretty load dependent. We know that because the tissue Doppler is less load dependent. It's the flows, the actual blood flow is the stuff that's super load dependent. That was the whole thing that was great about tissue Doppler, right? It was meant because it's less load dependent, and that's why it's meant to be a good marker for systolic function as well as diastolic dysfunction. So
have you got an explanation for that in terms of, is it like interstitial edema that causes the E primes to change more slowly, or is it just the fact that bioenergetically it's not relaxing well?
I was just thinking, because you're dealing with one's a solid thing and one's a flow thing, blood, and I always just felt that it's easier to change the flows, because we're looking at blood flow with our pulse wave Doppler here, but you're looking at tissue movement with your tissue Doppler imaging, and so I don't know the exact answer. but we don't have a lot of data looking at this stuff over a linear period. I'm still trying to figure out how to do a little study looking at some of this, but I'm guessing that you're going to be right. The small study that I can think of definitely shows that.
Cool.
Oh, come on in. We're almost finished. But again, I don't feel like some of this stuff's that subtle. It just, it's, but really important to at least try and assess it. If you're going to start someone on a pulmonary vasodilator, make sure that the left atrial pressure isn't raised, because that sure as hell can make things worse. So I think that's maybe just the one thing I'd like to encourage us to do, me included, is to make sure we do an assessment of left atrial pressure when we're starting pulmonary vasodilators. Okay, so I had that patient labeled as significant post-capillary pulmonary hypertension, diuresum, get them normal left atrial pressure before you start the nitric oxide. Yeah, well, that's about it really. I think maybe just in summary, just again saying that I think left atrial pressure is a really important part of the cardiovascular system. It's particularly important, I think, in patients in respiratory failure who have got a precarious fluid balance. You're thinking about starting inhaled nitric oxide, things like that. So no single parameter's perfect. I think lung ultrasound can be quite useful, but most of important, I think we need to have an idea of where we're starting, the clinical context, how that left atrial pressure might fit into that, and then see how it changes over time. So using that echo as a monitoring tool. Anyway, thank you for helping join me on my journey of trying to understand diastolic function in the critically ill. And I, as I repeat, I don't think I've got it absolutely perfectly figured out yet, but I don't know. I'm just trying to keep it simple. I'd love to hear your thoughts. You got any questions you'd like to ask?
Thanks, Sam.
Oh yeah, hang on. So we got a question from Umi. Yep.
With the L,
Yes.
do you only get it in severely raised?
No, do you hear that? So that was a question about the L wave. I don't know who heard, and then said, do you only get that in severely elevated pressure? So the L wave is meant to be seen in moderate diastolic dysfunction. So it can be moderate or severe. But you can also see it in young people, as it's almost like a reflected wave because their relaxation is so good, or you get it in people who are bradycardic. And I think in those two patients, you can have normal left atrial pressure, but still have a L wave. And that's because of reflected sound waves. At least that's what I think it is. Yeah. So otherwise, it's a sign of moderate diastolic dysfunction. Make sense?
Yeah.
Cool. Any other questions online? I appreciate you asking them as we're going along. I like it when people interrupt. That's awesome.
Thanks,
Well, guys,
thank
you very, very much for your time. I hope that was useful, and I'll try and keep the clinical cases coming, and I'll try and write a plan of what we're going to do later on as the year progresses. So we'll be a bit more organized, but be patient with me. There seems like there's a lot happening at work. Cool. Thanks, guys. Thanks for joining, Lucas. Great to meet you.
Thank you, Sam.
See you. Bye.